All right, so we are going to go ahead and jump in, although there may be some folks continuing to roll in. I know Wednesday afternoon tends to be a bit of a crunch time. I'm very glad to see all of you here today for our webinar on designing a medical respite space using a trauma-informed approach for a healing environment. I'm Caitlin Sinovic. I'm really excited to be here and have this conversation today. I am going to give a disclaimer. I am getting over some respiratory illness, so I am armed with cough drops, but apologies for any pauses that might happen throughout this conversation as needed. So just for those who don't know me, I know there are some familiar faces here in the room, but I am a program manager for the National Healthcare for the Homeless Council and National Institute for Medical Respite Care. I'm also an occupational therapist by training, have done some direct experience within healthcare for the homeless and medical respite setting. Regardless of the role or kind of title that I take, I think one of the biggest things that's really important to me is advocating for healthy, healing, and restful spaces, especially for folks experiencing homelessness and others who maybe don't have those opportunities throughout the rest of their lives. One disclaimer, this conversation is about creating a trauma-informed environment. So there may be a few examples that describe potentially somebody's traumatic experience. With that in mind, please be sure to take care of yourselves and take a break as needed as we continue this conversation here today. So I think a lot of you in this room here are in this webinar today are very familiar with what medical respite care is. But just in case you're new to respite, I'm going to provide a little bit of a background on what it is and really what we're trying to do in respite. So the definition of medical respite care is post-acute care for people experiencing homelessness who are too ill or frail to recover from an illness or injury on the street or shelter, but do not require hospital level care. So the goal really of medical respite is to be a safe place for somebody to move to from the hospital, to recuperate, recover, and then really think about healing and the next step to continue their health. We know across the country, there's over 130 different medical respite programs. Each program is really unique, and everybody has a different number of beds, housed in different types of facilities, different lengths of stay, staffing. Programs are really unique and built on the community needs that exist where they are and to meet those needs of that community. So when somebody comes into medical respite care, there's some really key features, right? So one of the biggest things is making sure that the person is connected to primary care and has connection to care to keep them healthy after hospitalization. We also know that there needs to be some clinical care that happens while in respite, again, to support that healing process. And another really key essential element is case management and care coordination. Health is just not about physical healing, but it is about how am I able to take care of myself, my body, what resources do I have? And case management is such a critical component of that. And then finally, in respite, we're hopeful that people also learn self-management skills. Perhaps they have a new diagnosis or haven't had the opportunity to do something to really focus on their health prior to respite. And that's one of the key features of respite, is the space to really be able to do that because our basic needs are met. We're talking about environment in today's webinar. So I wanted to share just a little bit of data from, this is data that's available from our website, the state of the field, where medical respite programs are located. So there's a whole bunch of different types of facilities that folks use to provide respite services. You can see here that the majority are based in a shelter or identify as an emergency shelter. Also, there are several programs that are standalone facilities, and many operate from a number of other creative ways through transitional housing, using motels and hotel vouchers, which was definitely more prominent at the height of the COVID-19 pandemic, and other sorts of facilities. So the goal of today's conversation and strategies presented are hopefully going to be applicable to you despite the type of facility that you're located in. We really know that programs have unique sets of resources, and the idea is that providing a trauma-informed environment is something that anybody can do. So again, a lot of folks in this webinar are probably very familiar with what trauma means, but I'm going to do a little bit of level setting again. When we're speaking about trauma, we're talking about experiences that cause an intense physical and psychological stress reaction. Trauma can be a result of a single event, multiple events, or a set of circumstances experienced by an individual that are physically and emotionally harmful and threatening. For those of us who've worked a long time in homeless services, right, the experience of homelessness in and of itself can be traumatic among many other experiences a person might have. And trauma can have really lasting adverse effects on somebody's physical health, social, emotional, and spiritual well-being. And it can show up through how people portray their emotions, their thoughts, their behaviors, how they interact and engage with others, and even physically. So trauma really has a whole body, whole person effect. And that's really important because we know that there's a really high prevalence of trauma among the population of people experiencing homelessness. Because of that, then, we want to provide trauma-informed spaces and services. What does it mean to be trauma-informed? It means that your organization realizes the widespread impact of trauma and understands the different paths of recovery, recognizes signs and symptoms of trauma, responds by integrating knowledge of trauma into policies, procedures, and practices, and avoids actively resists re-traumatization. So the idea behind this is not only do we recognize that trauma might be prevalent, we recognize what that might look like for different people, and then we create services and environments where we know that we want to prevent further trauma and be supportive for people who have experienced trauma. So trauma-informed care, some really key components of that are first, understanding the right to self-determination, collaboration and mutuality, so engaging with the person and not just telling the person how to do or be or respond, making sure that things are safe, and really, in essence, shifting power dynamics. Again, it's less of that sort of, I'm telling you how to do this, and giving ownership and power to the person who may have experienced the trauma. Within medical respite, as I mentioned, there's a really strong need for trauma-informed care because we know there's such a high prevalence of trauma among people experiencing homelessness. And this can be both a result of trauma that was experienced prior to becoming homeless, which may have contributed to why the person became homeless. And then we also know the experience is traumatic, and therefore people will be entering our programs with trauma. Specifically in the medical respite setting, there may be additional layers of trauma because somebody has just experienced an acute medical event, and that in and of itself can be traumatic. The person might be acknowledging a new medical condition that they're going to have to manage, which can be very stressful and overwhelming. There may have been traumatic experiences that happened in the hospital. Unfortunately, folks don't always receive trauma-informed care and will experience stigmatization in the hospital itself. And then maybe perhaps that medical event was something that occurred to cause hospitalization, such as experiencing an assault, being a victim in a motor vehicle accident. So even the event itself, along with the physical injuries, can be a source of trauma for individuals. And then what does it mean when we're talking about the environment? Environmental factors are defined as aspects of the physical, social, and attitudinal surroundings in which people can live and conduct their lives. So I think that's really important. I think when we talk about environment, we often think about the physical space, but really the environment is made up of all of these different things: natural elements, man-made structures, material resources. What am I able to get or not get? Can I easily buy a bottle of water when I'm thirsty? Politics and policies, which we know have a huge impact on what resources people are able to access, where they're able to stay, what they're able to do freely in the community. And then elements of time, right? How the day is moving around. All of these things together can either facilitate somebody's ability to function, or they can be barriers. And in some cases, the environment itself can cause a disabling experience as opposed to the person. So why does the environment matter? The environment, right, is where we spend a lot of our time. It's where we are. It's where we function and how we take care of ourselves, right? And there are little bits of the environment that we don't always realize really make a huge difference. So for example here, right, so this is examples of what we call hostile architecture, right, and unsafe environments. And these are specific to people experiencing homelessness, right? Although they may appear subtle, you may not recognize that, but in the top left corner, And we have pictures of benches that have basically wood nailed halfway through them, right? And the goal of that is to prevent a person from laying down and being able to sleep. Another more subtle example in the bottom left is in the New York City subways. This was a recent addition. They took away all seating benches and made these sort of lean against spaces, which are were again intended to prevent folks from sleeping there. But when we think about that, who else is this affecting, right? And making a hostile environment towards anyone with a disability who may need to sit down, people who are tired after a long workday, right? This changes the environment of waiting for the subway. Additionally, at the bottom and the top right, we obviously have some more aggressive forms of hostile architecture. We've seen this a lot in communities with encampment disruption, and then really significant structural spaces to keep people off, essentially. And again, this can happen really subtly in policies too, right? So no public restroom, right? Not giving people access to places to use the bathroom or take care of basic needs. So when we're thinking about medical respite, it's important to remember sort of that larger environmental piece, because those are the things that people are experiencing day to day, especially when you're experiencing homelessness, right? So there's a lot of experience and exposure to really hostile and unsafe environments. And when we're in respite, we want to promote a sense of healing, right? And we want to create a space that's safe, that's comfortable, and really sets up and facilitates dignity among the person. The goal of respite is healing. So how do we make our environment a place where somebody wants to be, wants to spend their time, and wants to heal and rest? And really beyond that part, we want somebody that when they walk through those doors feels like they belong here and that they're welcome here. And kind of from a pragmatic perspective, we also know that a safe environment is supported by the standards for medical respite care programs very explicitly through standards 1, 4, and 7 regarding safe and quality accommodations, having a safe place to provide high quality clinical care, and then having your staff be equipped to address the needs of people experiencing homelessness. The physical environment can be set up to be trauma-informed, but your staff have to be trained in trauma-informed practices to be able to really implement that. And trauma-informed really happens both when the physical space is set up and the people providing services are equipped to do that. And there's a really incredible group of folks who have developed the trauma-informed design framework, which is freely available online from ShopWorks, is the organization that's put that together. And they've identified 3 really key tenets of a trauma-informed design, which focuses on choice, community, and comfort, right? So building a place where people have choice about what they do and how they interact with the environment. Community is a place that promotes a community engagement, a sense of belonging. And then comfort, which is really, how do I feel comfortable and safe in my space? And the idea behind this is really designing for joy, dignity, and healing, which I think, although this was centered more around permanent supportive housing, has really great application to respite. So the next piece that we're going to really jump into here is how to, right? What does it mean to have a trauma-informed environment, and what might that look like? So the first sort of component that we're going to tackle here is about choice. And to do this, we are going to actually do a little bit of an activity together. So I'm going to invite you all to join in Mentimeter. You can get there a couple of ways. If you have your smartphone handy, you can scan the QR code on your screen and it will take you to the page. Otherwise, you can log in from any device and go to menti.com, enter the code on your screen, and join. So I'm going to give everybody a few minutes to come in here to kind of engage in our activity. All right, so we're gonna go ahead, and I promise this is gonna be kind of a fun one. So what we're doing here is an activity called This or That, which is a fan favorite here at the council. So on your screen, I would like for you to vote for which bedroom space feels the most restful and calming for you. What would be your preference? All right, so this group is strongly favoring option 2. And again, if you were selecting a space to sort of cozy up, read a book, listen to music or a podcast, which of these spaces would you pick? Option 1 or 2? Okay. Lots of folks with an outside porch space. All right. And then, oops. Sorry, folks, lost my screen. All right, and now for if you were someone who was opting to go outside for a run or a walk or a bike ride, which of these locations would you be your ideal to do that activity? All right, this one's kind of a toss-up, and there may be a good number of people who've said, I would like option 3, which is I don't run, right? So that might be one too. All right, and then if you were gonna find a place to sit and relax and enjoy your time off, which one of these would you select? We have some mountain folks today, although this one is also pretty close. And then finally, if you were deciding to go to the beach, which of these beaches, right? So we have sort of the southeast coast, and then we have more of our northwest coast type of beach. All right, this is another close one here. So we're going to come back to our presentation. And the real kind of practice around that, right, is there was, in any of those particular examples, there was not a right or a wrong choice. There was just a choice of what your preference might be. And I think none of us would particularly argue that any of those spaces were worse than another, right? But it's really more, how does a space speak to you and how does that make you feel comfortable? And I think it's important to note that with trauma-informed care, right? What is trauma-informed to one person may not be for somebody else. So I'm going to present a lot of strategies and solutions today, but there's not a one-size-fits-all approach to this, right? Because trauma-informed care is really individual. How you can meet those multiple needs, though, is really thinking about flexibility. How can we present choice and option throughout our space, and also thinking about rigidity and rules and where we can be flexible, right? One example might be, we have a rule that everybody gets one pillow and one blanket. Everybody sleeps differently, and what is comfortable for you and for me might be very different, right? Some folks, especially if they're healing, might want 3 or 4 pillows to help prop up, and somebody else might want 0. Is there a reason for that rule to be in place, or is that a space that we can be flexible and provide some choice? We also want to note and give the caveat that you can make a beautiful, the most trauma-informed environment possible, and you're still not going to necessarily be able to eliminate all triggers or past traumas, right? The environment is not the full solution. And that is where the staff training piece is so important, because we want to make sure that staff are trained to help support folks who are experiencing symptoms of trauma, and having a space set up to do that is only going to help that. So how do we provide choice in medical respite care? Ideally, we think about how can we make some choices around when people do certain activities, right? Schedules and timings. Certainly, we need to be able to provide meals and we can't have food out all day, but other things, do we require people to get up and take a shower in the morning before meal times? Or can we let people do their ADLs throughout the day? What are different ways we can incorporate routines? And how do we allow for some different private spaces in which to do those things? We also want to make a choice around participation. Not everybody's having their best day all of the time. And so some days there might be a time when people need to be alone. And there might be a time when people really need the opportunity to sit and engage with others. And having that option is really important. Other sort of physical elements around choice can also be lighting, right? So there are certain types of overhead lighting that can really be triggering for some people versus offering some options for indirect lighting. Can we provide a lamp or some of those little clip-on lights for people? Can we provide night lights or blackout curtains if somebody needs full darkness to sleep versus somebody who might not like that, and having those sensor lights. The ones that's pictured there are very low cost, available on Amazon. They just plug into an outlet and can help provide just a little bit of low light at night that's usually not too distracting. Other opportunities for choice, again, I gave the example of pillows and blankets, right? How many or what type? And seating options can be really, really critical to support different types of bodies and needs. Some people, to get up from a chair, really benefit from the support of having those armrests to be able to push up off of. Some people find chairs with armrests really uncomfortable and may not fit well into chairs that have different armrests that are not extra wide. So providing a lot of these options, again, helps support choice and comfort in the space. Our next key element is safety here. And we need to think about, what does it mean to be safe? When we're thinking about safety, there's both physical safety and emotional safety, right? Is my body safe? And is it safe for me to be who I am, express myself, and interact with others? So when we're setting up safety spaces, we're going to think about both. As I mentioned, I'm an OT, so accessibility is something that I'm very impassioned about if you talk to anybody who's known me. But it's really important that medical respite spaces are designed and accessible to individuals with a variety of needs. I think a lot of times we think about mobility and accessibility. We also need to think about other types of physical needs, cognitive accessibility, and emotional accessibility. And we want to do our best as medical respite programs to follow the guidelines for the American with Disabilities Act. Not only because it's required by law, but because in respite, we're getting people who are going to have all different types of diagnoses, health concerns, experiences, that the more accessible we can make a space, the better we are able to be to provide a healing space. And one step beyond accessibility is inclusivity, right? So we can make a space accessible, but it's not necessarily inclusive. And the next step, I'm going to show an example of what that means here. So in this first picture here, what we can see here is that this is probably not a very accessible space, right? You have a front entryway that only has stairs. There's no alternative except to get up the stairs here. So we're going to identify this as not accessible. The next space here has an accessible entry. So the front entryway has stairs, but they have an alternative ramp for somebody to get to. It's pointing around to the side of the back of the building. In this example, it's accessible, but it's not necessarily inclusive. This final example here, we see the front entryway, and the ramp is located right next to the stairs so that everyone is able to enter through the same doors. This is accessible and inclusive. ADLs are a really key component for everybody to take care of their day, we want to try to make our spaces accessible for ADLs. You can see on the far right, this is a fully accessible bathroom, a picture of one that's in a medical respite program. This may not be feasible for every program at this particular point in time, but there are other smaller things that can happen to make your space more accessible. Things like removable shower benches, installing grab bars, installing non-slip tread really can make the space safe for everybody. Grab bars are good for anybody, just in case of a slip, similar with non-slip tread, and can be done in spaces that you currently have, even if you don't necessarily have a renovation budget. But this can help somebody feel much more stable in doing their ADLs, which is such a critical part of our routines. As I mentioned, we want to make sure that our spaces are not just accessible for physical, but also for different cognitive levels that might be happening within our respite program. Examples might be clear signage. As you can see pictured here, there's a sign above the bed that tells the person, who their people are to get to. There's a small schedule there and a calendar. Things like visual arrows throughout the building or spaces. We saw a lot more of these in terms of reminding people about physical distancing. Those are strategies that can help with wayfinding and people know where to get what they need in the building. Making sure things are organized. So how many of you have seen or have a bulletin board like this, right? Hard to find and identify information on that. Instead, thinking about how you can declutter so that key and essential information is much easier to access. And then finally, do you have a designated staff person who's able to answer questions? I think sometimes it's easy to say, oh, well, the case manager or the care coordinator can take care of all that. But they are very busy, right? Meeting with clients and doing different jobs. That sometimes it's nice just to have a central person on the unit, a milieu manager, a tech, whoever that might be, front desk person, who can answer basic logistical questions so that people can access and get what they need and not necessarily disrupt the flow of other work that's happening. Another key piece of safety is really security of belongings, right? We want to recognize that a lot of folks experiencing homelessness have probably experienced significant loss of their belongings in the past, whether that was by losing items or having items taken from them that occurred with loss of housing, again, encampment disruption, that it's really important to make sure that we're able to keep people's stuff safe. And we want to make sure that people can access their belongings without having to talk to staff, right? As we mentioned, people are busy. We might not have 24-hour staffing. So can people get to these really basic items that they need and be able to store them safely, such as their phones, their bags, their ADL supplies, whatever that might be. Some different storage options, again, can be really flexible depending on the space that you have. Smaller lock boxes for things like wallets or medication, providing lock storage underneath. If you have individual rooms, how are you securing those individual rooms with people's belongings in it? Having individual lockers in rooms and also in common areas, but having a lock that the person can lock up their spaces. And then some programs have even been able to provide additional storage units outside of their building that they are able to put larger belongings in that don't necessarily fit within the medical respite space, acknowledging again that people might have some things that they don't want to lose while they're in respite. Another key piece of safety is privacy. So we want to make sure that people have adequate privacy to do things like self-care, rest, health management. Certain parts of health management, people don't necessarily want others to know what medications they're taking. Maybe they're injecting something as a medication. That's not something people want to do in front of others. We also want to make sure that they have private space to do phone calls, telehealth appointments, and meet with providers on site. When we're promoting a harm reduction environment, harm reduction and privacy can coexist. And one of the key pieces about this is communication. Again, on this slide here, we have a lot of different options about how somebody can provide privacy depending on the space that you're in. Certainly individual rooms. But again, a lot of us, as a result of COVID-19 and programs, had to think about how to divide up spaces for separation. Those are some elements that can be implemented and included to help with privacy, even in more congregate spaces. I really love the picture at the bottom of the private bathrooms. I think this is much more secure and safe feeling for an individual in a congregate bathroom to have a door as opposed to a curtain that anybody could open and close at any point in time. And then within medical respite, so the safety piece and security is really important, but we want to go beyond necessarily just privacy to promoting health and well-being. So we want to create spaces for community, right? People are living together, and often people are more able to get along or get along a little bit easier when you get to know the person and you have a relationship with someone. So certainly a space for formal groups when that's safe, but also, do we have a space for informal connection? Can people sit down and play a game of spades or a game of checkers, or just connect over something that they have in common? We also want to provide opportunities for calm, right? Life can be very chaotic. It's stressful managing a health condition. There's a lot going on. Spaces that people have to be in are very chaotic, right? Going down to a Social Security office is very busy. So we want that place of respite for people to be able to sort of calm, to center. And often this is a really good de-escalation strategy. So providing a lot of spaces for people to have that quiet. And again, if you're in a congregate space, even smaller strategies where people can create that sense of quiet, like through noise canceling headphones, just to sort of drown out what else might be happening. And then again, providing some opportunity for activity here. So are there spaces for people to engage in leisure? Things that they enjoy doing IADLs such as laundry, exercise and movement, and other health activities. And then potentially accomplishing other goals, right? So perhaps they're filling out SSI paperwork or preparing for a doctor's visit. Is there really an adequate space to sit and be able to do that? And somebody's not necessarily kind of hunched over on their bed trying to write, but do we have a space that people can engage in those activities in their environment? And I see a quick question in the chat here, an ADL versus IADL, and I'll address that really quickly. Activities of daily living are those basic activities such as showering, dressing, feeding, toileting, hygiene activities. IADLs are instrumental activities of daily living, and those are things such as laundry, shopping, taking care of your home, budgeting, some of those more complex day-to-day tasks, but aren't necessarily necessity self-care activities. If that's kind of a quick differential on that. And really, when we're thinking about creating these trauma-informed spaces, we want to think about health and well-being, like how can we do that whole, kind of all at one time. This picture is an example of a group within a medical respite program. There was some plants that were donated to help green the space. And the individuals in this group are sort of tackling a few different things, right? Building community, working together. The folks that were involved in replanting these were people who had a history of landscape work and enjoyed that, hadn't had an opportunity to do it in a long time. But we're also really vital in setting up, not just replanting things, but setting up the plant care and what needed to happen with that. And then additionally, because of different medical conditions, this was great practice for them in terms of energy conservation, balance, mobility, and strength building. You can tackle a lot of things in one activity. And as you can see here, this wasn't necessarily a robust, large, or brand new space, but being flexible and being willing to think about, it's okay if we might get a little dirt on the floor, right? We can sweep it up to help promote that opportunity. So it wouldn't be a conversation about medical respite care if we didn't talk about the challenges, right? Because nothing is ever really truly easy or black and white with this. So we're going to talk through that a little bit. So some of the challenges, especially in a trauma-informed environment, is that it can be hard to be flexible and accommodate everybody's needs. For example, you might have somebody that requires a service animal, and you may also have somebody at the same time who had a traumatic experience with the dog and doesn't want that service animal in their space. Whose need is most important? And you really can't pick, right? Both people have valid experiences. In those types of situations then, right, you need to think critically about how can I communicate this with this person? How can we accommodate everybody's needs? And if we can't, communicating that with the person, a flat no, period, end of sentence, can cause a lot more frustration than an explanation about why something is the way it is. We also need to think about what's feasible within a space. A nice soft plush velvety beanbag might seem really comfortable, but probably can't safely be maintained within a respite space. So it can be challenging to find that balance between what's durable and safe and can be cleaned versus what's going to provide some comfort. We also have to recognize cost as a barrier. Again, not every respite program has a robust budget to invest necessarily in these different things. So thinking through what can we do now, what's within our budget, and what can we plan for costs in the long term. Additionally, programs aren't always in control of their environment, right? You might be in a partnership with another organization or entity in control of the environment. Sometimes missions and values don't fully align, where trauma-informed care is really a priority for you, but maybe not the other entity. And there may be simple procedural barriers, such as following fire codes limits the amount of things that you can have in a space or on a wall. That doesn't mean you can't do nothing, but I think it's important to work together to figure out what would be acceptable and not. Even small, subtle changes can make a big difference. We also want to note the challenge. There sometimes can be a fear or concern of somebody getting too comfortable, right? If they move in all their belongings, getting too comfortable in a space will make it hard for them to want to transition out. Medical respite is short term. I think it's really important to recognize that comfort is still doable. And the key again here is communication about the expectation of the respite stay, talking about discharge planning and not having that be a surprise for the person, and thinking through some of those alternatives such as offsite storage where people can safely bring their things, but still kind of minimizing stuff that comes into the respite program. And then in some cases, this can require a paradigm shift, right? If your organization is working towards trauma-informed care and isn't there yet, that can be hard to change how you do things, to question current practices and think, oh, maybe we're not doing this in the best way or the most trauma-informed way. That can be hard. Change is difficult. And so it's just something that to be prepared for. You might not be able to walk in tomorrow and say, we're going to do all of this differently, right? It might be a kind of a change over time to help us get there. And in regards to the paradigm shift, I think sometimes it's very easy to think about, oh, well, this is a group of people who've experienced homelessness. They don't have resources. They should really just be grateful for what's available, right? What we have. And I would challenge you to maybe think a little bit differently when using that trauma-informed lens of those who have really been through the most probably deserve the best, right? The most healing, the most comfort, kind of the most resources to be able to heal and move into recovery for themselves. So that was a kind of a huge information. And as I said, it can be challenging to kind of make these changes. So we're going to talk about some strategies of where to start. So first, we're going to do a short activity. I have some images on the next slide. So feel free to respond in the chat to the first picture about what you would change first with that. So here's our picture of a congregate medical respite space. So feel free to throw in the chat, like, what are some things right away that you could do to make this environment a little bit better? Or also feel free to jump off mute and throw out your ideas as well. Great, I see lots of ideas around storage, right? Whether that be bins, a dresser, a closet. baskets, nightstands. Absolutely. Yeah. So storage seems to be a big issue, right? Both because storage space and wall organization, great. Yeah. There's some issues here around safety, with having all of these belongings around the bed and in a fear of tripping and falling, right? But also this person's belongings are sort of out in the open, not very private, not very safe. So I'm going to show a picture of what happened. Sort of this was an initial first step, which recognizes a lot of what you guys threw out there. We have some wall organization above the bed with a whiteboard and a calendar. It's hard to see, but there's a very small white hook at the top to hang belongings on. And then some bins next to the bed, pulling the bed out so that there was access to the outlet to charge the phone there. So I would say that this was a really good start to improving that space. And I would agree in the chat, people should not have to store their belongings in trash bags. I would agree with that, right? Dignified is another key piece of this and providing a place to store their belongings. So based on this one sort of level up improvement here, where could we go next? What would be the ideal? What would be sort of the dream way to fix up the space? And again, feel free to throw some ideas in the chat. I see someone with room darkening blinds, right? Like, so actually being able to control the light in the space better. But what are some other ways? What are some nice things that can happen for this? I love your ideas. Yeah, so changing the color on the walls, potentially adding a lamp, providing a comforter or throwing in different colors, right? That could happen through the blanket, through the wall space. Built-in cabinets, right? So there's plastic bins here. Maybe we could move towards having some more substantial furniture. Locks on the storage, right? That's a good note that there's not locks on these bins here. Pictures and art on the wall, absolutely. Yeah, some really great ideas here. So thinking about where to start when you're thinking about your own program and what we can potentially do, these are recommendations going back to that trauma-informed design framework. To think sort of on these are sort of 30,000 foot recommendations here, thinking about the cultural context and who it is that's in your community. The environmental context, as we talked about, not just the physical space, but historically what's happening, economic context, the systems that people are interacting with, how does that influence their engagement with their environment, right? And that can be as simple as thinking about what pictures go on the wall, right? And what are those pictures representing, and making sure that they're not speaking to something that is not really acceptable to your population. And again, thinking about the lived experiences and how people might have interacted with the world around them. From stepping down from that 30,000 foot view and a little bit lower, how do we do that? My number one recommendation is to start with consumers, the people who are living in the space. Ask them, ask them through individual conversations. You can have more formal focus groups. You can have a question about it in your exit surveys. And even just paying attention to the feedback you get, both positive and negative, about the space itself. Like, oh man, there's not enough outlets. We always have to fight over who's charging their phone. Like, hear that and think about, okay, that's a big issue. How can we resolve that in the space that we have? Little things like that. Oh, this room is really bright. It's hard to see the TV. How can we change that to make that a more comfortable space for people to be in? And then for yourself, you can observe the space, right? Are there places that are immediate safety or hazard risks? Again, around falls prevention. Are there spaces that feel congested and kind of like, oh, I don't want to spend a lot of time here, to places that feel like, oh, this is a nice space. I wouldn't mind sitting and reading my book here. You can also pay attention to and notice if there are spaces where conflicts occur, right? Are there places of congestion where people tend to rub up against each other? And how can we think about reorganizing that space to prevent that? Also looking at your policies and procedures. What's helping you have a trauma-informed environment and what's a barrier? And what maybe do we have flexibility to change? And then again, going back to staff training, right? You can set up a beautiful building, but if your staff don't know how to do trauma-informed care, right, it's not going to be used to its full potential. So thinking about, are my staff equipped really to implement trauma-informed care, both by training, by the resources that they have, by the time that they have, and how things are structured. Where are the difficulties and what can we change? Other ways to think about where to start: developing a consumer advisory group for ongoing feedback, right? Once you've implemented changes, you're going to want to evaluate, right? What happened? Did this improve? Did this not? We don't want to get consumer feedback at one point in time and say, oh, we've done our due diligence, we can move on, right? We want to ensure that that voice is heard throughout and really engage people in the redesign process, right? There might be folks who are very interested in helping in that process and giving feedback on colors and style, and we'll bring up things that we haven't necessarily thought about, right? The more voices, the more perspectives that get represented. And again, thinking about what can we do immediately, right? Maybe we can provide those low, the word is escaping me, the night lights, right? That's something that's a low cost that we can provide in our space and doesn't require big structural changes, but might make a difference to someone, versus very large changes. Maybe we want to reno our bathroom to make it more ADA accessible. That's going to require some fundraising, some time, and some planning. And what can we control in our space? And maybe what do we need to work with a partner to be able to do? And thinking about whose support do you need to do that? And how do we communicate the benefits? Sometimes it's not immediately obvious where trauma-informed environment and care can provide benefit, but if it reduces, right, moments of escalation among people in the program, that's a huge benefit. So again, these are some tips for success. I sort of went over these a little bit here, but really, again, this is from the trauma-informed design framework, so this is very structured. But again, some resources to think about: how do we identify the problems? How do we implement changes? And then how do we evaluate the successes of that? And I want to note, you don't have to do it alone. You as maybe the program director or the provider in the program, you don't have to figure it all out yourself. There's a lot of people who can provide some insights and supports for this process. But there's a lot of programs who've sort of taken on doing this trauma-informed design space, who are really, really willing to provide their recommendations and lessons learned. Additionally, here with the council and with NIMARC, we're happy to provide some TA around that. Additionally, for accessibility, you can use an ADA consultant, an accessibility consulting, to figure out what changes you need to your space to meet ADA requirements. Less formalized is maybe engaging with occupational therapy, physical therapy, and especially student programs who can do an environmental evaluation of your space and identify some safety concerns and fall risks that might be there. Additionally, greening the space. There's a lot of community groups that do different projects to create plants, even in urban areas. So figuring out who those groups are and who might be able to donate time or supplies to make that happen in your space. Again, recreation and leisure, there's OTs, there's recreational therapy, often are looking for opportunities to volunteer or student projects, things like that. Again, to provide that structure within your space. Safety and security supplies can be something that you fundraise for, or if somebody wants to make a more tangible donation, you can kind of make those requests, both for durable medical equipment, certain types of supplies, furniture, and bedding, right? Sometimes people like to put their money towards something they can see, and that might be a great focus of your drive. And then finally, if you're thinking about design and redesign, there may be architectural student groups or even firms who are looking for community engagement and ways to volunteer their time that can help you figure out how to design the space. And basic, we brought up art as something that can be done, right, to make the space more friendly. Using consumer art, there's often, probably usually within our respite program, a couple of people who are really artistic and can put together some pieces, as well as local art groups. And if you can, think about compensating your consumers for their time, especially if you're asking them to create something for you, which is very different than somebody offering to give you their art, but thinking about how we can compensate people for the work that they're doing for our program. All right, so I'm going to pause here for some questions, and I see there's a few in the chat, so I'm going to try to scroll up a little bit to find them, and a few suggestions here as well. Starting from the bottom up here, so somebody noted that investing in earbuds from Dollar Tree significantly reduces conflict over noise complaints. Yes, that's a beautiful example of a low-cost change or strategy, right? Dollar Tree, very cost effective and gives people control about the noise that they're hearing in their space, can be really great for congregate environments, especially, or any sort of central space. I see a question, sorry, I'm trying to get to the beginning of it here. With limited privacy like shower curtains for coverage and bedroom doors, what are some caring ideas for supporting folks with different gender identities? And that's a great question, and I think that can be really challenging. I'll pose it to the group. I'm going to give my initial thoughts, but if there are folks here who have encountered this and come up with some solutions, I welcome you to throw those into the chat as well. Different things you can do is, ideally, the ideal, right, is that everybody has an individual bedroom and bathroom space. The reality is that that's not always possible. But one thing to think about is there a bathroom space, just one bathroom space within our facility that we could transition to being an all gendered bathroom? And in that all gender bathroom, it's more individual so that one person would be in there at a time and can provide some privacy around that. Other things to do to work with a person individually might be identifying a time where the bathroom is not being utilized as frequently and seeing if they'd be willing to use it at that point in time. So, for example, if a lot of people are showering in the morning and at night, maybe they'd be willing to do their ADLs like at to shower at 2 in the afternoon. But having a staff person available to make sure others don't use the space at that point in time, or providing some safety. I welcome other ideas or suggestions though within the congregate space. I think structural changes are the long term to work towards. Again, privacy curtains between spaces can be really, really helpful. And, as providing private rooms, and not just necessarily for the person who identifies with a different gender identity, but having those private rooms accessible for anybody to use at different periods of time throughout the day, whether it is to do healthcare or to do self-care, or just have some time away from other people. I'm curious if anyone else has ideas on that. And we do have a webinar training. I don't have the link handy on providing gender affirming care. And so that might be a good place to start as well in terms of thinking about not just structurally, but also training your staff to be able to provide care for folks with different gender identities. Yeah, I think this is another challenging one in the chat around personal food. That tends to be a conflict with folks staying in that medical respite facility, taking other people's food without permission. Yeah, and again, I'm going to open it up. You all are in the respite programs day to day. If anyone has found some successes with that, different options might be. Thank you, Stephen. So the gender affirming care webinar, Stephen posted a link to that in the chat. So I recommend, if you haven't taken that yet, to do that. It's a really great starting point to provide gender affirming care. Regarding the food safety or security, I mean, you can always consider thinking about how to provide individual storage that's a little bit more secure inside the refrigerator space. If it's one large refrigerator that people are accessing, smaller boxes where people can secure things, potentially even lock them. If you're not able, again, to provide that sort of individualized fridge space for people, because I think you're right, the challenge is you want people to be able to get to their meals without talking to staff, and making sure that people have ways to label their food items, and making sure that they can label, date them, that type of thing. How many medical respite rooms do programs have on average? Single or double occupancy? So to answer the question, I think there's quite a variety. I think the average bed number, and my colleagues Stephen or Krista can probably speak to this a little bit, I think is maybe 18 beds in a program, so 18 individuals in the program at one time. I think the structure of that can be very different depending on genders that are being served, if there's sort of a men's space versus a women's space, or if it's congregate. I would say probably a fair number of programs have double occupancy or congregate space where there's larger rooms, or maybe there's 4 folks staying in at a time, or up to 6. And then there are some programs who do have single occupancy, but again, those tend to be larger, more established programs that have been able to build their own facility after a while. But folks, feel free to chime in about your own program and how that looks for there. So the short answer, Lori, is that there's not one particular way. I think it's very dependent on the space that folks have. So, yeah, there's a few answers on the response here about setup. And yes, for medical respite program, this is a great question about, can the person stay in the room 24/7? So part of one of the key components of medical respite care is that the person has access to their bed 24 hours a day, in part because the person is healing, right, from a medical condition of some sort. That really the number one goal of respite care is to be able to rest and recuperate. So especially immediately out of the hospital, for some people that might be, a lot of time, or there are people who are undergoing dialysis and chemotherapy and different interventions that make them very tired. And so having access to that bed is really, really critical. That being said, there are programs that offer a lot of groups and programming throughout the day, encouraging folks to come out and join, be part of community activities. And another part of respite is getting the person to engage in community resources and care. So even though they have access to the bed, but supporting the person in getting to their medical appointments and meeting with their case manager and meeting with the care team, depending on how the person's feeling, that might be flexible if those visits happen in the room, or if those happen in a meeting space with a care manager. And folks are interested in the average length of stay in respite programs. We know, so Krista linked the state of the field, which has some data that we know from programs who filled out the directory and program profile. The average length of stay is 28 days, but folks, again, on this webinar, feel free to chime in and add because some are definitely longer than the others, 8 weeks. Yeah. And I would say the length of stay is influenced by a lot of things, right? One, it's, when the person is ready to go. It can be influenced by your funding source, your need to turn over bed capacity, where folks discharge to. If you are waiting to transition the person directly into housing, that tends to increase length of stay just because of the time that it takes to get folks there. But there are a lot of factors that might play into that. Want to make sure, since we do have a little bit of time on this webinar today, I'm curious if anyone has any other questions about the content in the trauma-informed environment space before I jump to kind of some questions for you all. So I'm curious, and again, feel free to share in the chat, or to come off mute and share if you're comfortable with that. You can raise hand or just feel free to jump in. But what are some strategies that you all have already done to be a trauma-informed space within your program? What are some things that have worked? So there's been a few examples in the chat here, but I'm curious for others, what are some things that have been really helpful? I think a few that came up before is folks have talked about the earphones to reduce the noise, offering lamps. I think art on the walls have been a big one. So those are definitely really great ones to sort of start with in your program, and don't require a ton of lift in terms of cost and action. Oh, thank you, Krista. Yeah, and storage, right? So being creative, I think, with storage. Oh, I love this example, having a nice shaded backyard area with 2 big gardening beds, growing vegetables that folks get to eat in their meals, and people really appreciate being part of that process. We're big fans of community gardens here, so I think that's really, anytime we can offer green space is fantastic. Every resident can choose a house plant. That's awesome. I love that. Bird feeders, yeah, that's another great example, right? Just kind of inviting nature and a calm place for people to sit. Library of board games, puzzles, recovery books. Beautiful, right? Again, offering choice. Everybody's interest in leisure is a little bit different. So what can you have out that might pique the interest of somebody and also is accessible and feasible in your space? We've talked about a few challenges already that folks have brought up here, but any other challenges that people face in terms of implementing sort of this trauma-informed environment, some barriers that you'd like to share?
I can go. Hi,
Yeah,
everybody. It's Julia. Hi. Yeah, one of the biggest challenges, out of all the behavioral agreements that people agree to when they come into recuperative care is that to not eat, in the unit, and because it creates a gigantic mess and ants, and it can get out of control pretty quickly. And it's an ongoing challenge, and we don't want to, of course, exit anybody for doing this, because it's a fairly harmless violation, but at the same time we have to maintain cleanliness, and because it's supposed to be like a sanitary sterile space for healing. So I guess I was curious if other respites allowed eating in bed, or and how they handle the food situation in their unit.
yeah, I think that's a great question and relates to the kind of food theft question that came up earlier. So curious if other folks have thoughts around how they handle that, the food, and allowing them to eat in the sleeping space, or how that, maybe some alternatives. Looks like a common challenge, Julia, but maybe not one that has good solutions yet.
That's all right. That's all right. Thanks.
Sure. Yeah. Sometimes validation is nice too, to know that that's a struggle with everybody to do that. Yeah, because you're right. I think then, and that's bringing up an important point around the trauma-informed care piece of maintaining that balance of, like, yes, we want people to be able to snack, but this is also a place where people are doing personal care, medical care. We have issues with bugs, right? Like, we want to prevent that from happening. So noting where the balance is with your program and where you do have to make rules about certain things. Somebody did answer they don't allow food in the dorm areas, and they do check to make sure that there's not food in there, and provide a cup with a lid that every patient can go in the living room or the dorm room. So, and that may be a solution, is sort of just identifying a designated space where things can happen, and thinking about how different policies and procedures that are in place might impact use of that. So if the alternative is we have a picnic table outside that you can go eat snacks at, do we have rules around when people can come and go from the program, that even though we have this space, they can't actually get to it? So thinking about sometimes how those different things interact together. Sometimes it's easier to implement a rule when there's an alternative suggestion to it, as opposed to no, you can't do that, but then there's not direction about how that might happen. Without knowing specifically, Julie, I don't know if that's in your program or not, but some
Yeah.
things to think about.
So we ask everyone to go to the dining hall to eat, whether they can store their snacks in recuperative care, just don't eat them in recuperative care. And there is a bench in the hallway, but then it's in a gigantic shelter on the second floor. So the mobility issue to get down to the dining hall isn't so easy for some. So would be nice to have something a little bit closer, a closer alternative to eating in the unit. But yeah, it's an ongoing issue for us.
Yeah. Similarly, I think kind of that communal space thing, someone else brought up challenges around the common room television. Again, I'll open it up to folks here. Any solutions that you've come across to help streamline the schedule or content? Certainly everybody has different preferences for what they watch on TV. So how do we balance that and manage conflict, but still have that as an option for folks for leisure? Right. This is what, Krista, go ahead.
I was trying to wait and let other people if they, but that's a common issue even in my own home. So I totally understand that one. The challenges around TV. I mean, if people are not able to work that out themselves about deciding what they're gonna watch, you do a schedule, like a general schedule of how, like if there's certain people who want to watch one thing, then they get to watch that at a certain time and do it that way. But that's just one suggestion.
Yeah, and sometimes it's sort of that funny thing about we want to provide a lot of flexibility, but in some cases structure can be more beneficial and supportive in terms of like, we're always going to have the 6 o'clock news on. We're always going to have Jeopardy on, here's open time, providing signups like, okay, so-and-so really wants to watch a show at 2 o'clock. I'm going to sign my name up so that I'm going to pick the show that's watching at that point in time. One thing that is helpful, and I didn't think of this earlier in the response, but kind of around all of these challenges is some programs have identified having community meetings or community groups to come together and talk through what these issues and challenges are can actually be really helpful. Not necessarily to have a group where people are airing grievances necessarily, but to have a space where the folks who are living in the respite program can come up with solutions to the problems that are presented. And sometimes, in some cases, people are more respectful of the solutions of their peers, but also there might be ideas generated that are that we didn't even think of necessarily as staff. But sometimes those community building opportunities also can build sort of more mutual respect among people, and sometimes can mitigate some of the issues as people have more respect for each other, are less likely to take each other's food or argue about TV choices. Not saying it's going to mitigate all of that. That is a strategy that different programs have used in order to kind of navigate these challenges together and understand, where are these problems coming up and how can we work together to do it, as opposed to staff saying, okay, well, we're just going to go ahead and do it this way. Can be an option for that. So my last question that I'm going to throw out to all of you here is really, this is sort of an introductory. This is a presentation we were able to give at the national conference this year. And then also this webinar today, which to answer an earlier question, the recording does go on the website along with a copy of the slides. So that will be available to you all once we have that downloaded and then uploaded to the website. But we want to build out more resources. And so I'm really curious about what would be helpful for you all in terms of helping to implement a trauma-informed environment or resources around the environment in the space of medical respite. Open to really any and all ideas. Again, if you want to throw them in the chat or share here, what are some things that would be useful to you in your program that we could work on developing here? It's your chance to give us more work. And while we are thinking and strategizing around that. I'm also going to launch our poll about today's webinar, so I don't forget to do that as well. So if you wouldn't mind answering questions about today, but also thinking about what resources really might be helpful.
I have a thing that I think would be helpful.
Yeah.
On our end, at least, I would like to start providing some online trainings for some of our staff. Because we are 24/7, so it's hard to get all of our staff together at the same time. So if there was some online options that they could do, that would be great.
Yeah, that's a great question. And I promise I didn't pay her to give that suggestion, but that's a great intro as we actually have our medical respite online courses have now launched on our website. I'm so excited. So I'm going to put that link in the chat for all of you.
Oh, great. Thank you.
This is the direct link to get to it. You can also access it just from our NIMARC website. And once you go to our main page, you'll see Learning Portal, and that will take you to our learning management system. So we have 3 courses that are available now, one around harm reduction, one around discharge planning, and one around data and outcomes. But we are planning to have 8 available by the end of this year. We're going to roll them out monthly as they're developed. So there will be one around trauma-informed care as well, that we're hoping gets used by programs exactly for this purpose, for staff training, and having them as an online module will then make them really accessible to all of your staff. Well, fantastic question, and thank you. That was a great prompt for me to remember to talk about that.
Hi, this is Beth from Cleveland. I just was curious to know whether these slides were informed by working with any design professionals, and if so, you know, what potential there could be around engaging the architectural and interior design fields more in trauma-informed environments, you know, whether in medical respite care or just at large.
Yeah, that's a great question. So I can try to post the link here. So ShopWorks is where the trauma-informed, it's a group of folks that came together, architects as well as permanent supportive housing programs, came together to create the trauma-informed design framework. So some of that content was pulled from there in the publications that they have. They, I think, are one of those, spelled it wrong, so I can't find the link. I think sort of at the cutting edge of it, although I found more and more architectural firms that are really interested in these trauma-informed community spaces and are willing to engage with homeless service providers of different entities to figure out how to create really more meaningful spaces for people to be in. I will say a lot of it has been centered around permanent supportive housing as opposed to medical respite care. That being said, I think there's a lot of opportunity potentially to partner with that. And I think having this organization, the ShopWorks, is a really nice resource as you're engaging maybe with local architecture firms to be like, here's somebody in your industry who is tackling this already and doing that. And that was a good reminder. Thank you, Beth, because I do have a slide about some resources related to that up here as well. And again, these will be available in the when we post the slides as well. So Sharon, I see your hand up here.
Thank you. I will say, I so appreciate you bringing this presentation to light. We are actually contracting with ShopWorks currently for our shelter operations and the design of our new space, which would include our respite program. And they've been great about doing consultation because obviously they're out of Colorado. And so we're doing this kind of blended piloted model where we're going to do some on the ground work to help support their level of expertise. So they've been really open to this flexible way of doing this proposal and being able to do the evaluation pieces. And they've got a great team of social workers that really are, you know, they have that expertise to blend with their architect and engineering, you know, experts. So it's been very fascinating and very exciting to be able to partner with them in this creative way of getting some good feedback on what we're doing currently.
Thank you. I'm so glad you're here. I knew I had talked to somebody recently who was using ShopWorks. There's a lot of faces in here to catch. So thank you for that endorsement. And I'm glad that it's been a positive experience thus far. And they may have partners too, depending across the country, that they can recommend in terms of other folks that, people who do the same work tend to find each other and might be able to support different parts across different parts of the country too. Annie, I see your hand as well.
Yes, I wanted to bring up maybe hoarding resources. And so the stuff is sometimes a manifestation of people's trauma. And I think that that's, an area that maybe NIMARC and actually shelters, et cetera, could be more informed about since letting go of some of the limitation of the people's stuff in recuperative beds, respite beds, and as well as in shelter beds is sometimes very traumatic when they have to be separated from their things. So I think a better understanding and a focus on that would be helpful.
Yeah, thank you for that suggestion, Annie. Yeah, because it's a huge piece of it, right? Is, as you noted, there's so much trauma related around belongings and safety of belongings, and that can be a barrier for people entering respite and not knowing where their things are. And I think also recognizing that there might have been a loss of belongings that happened right before they came into respite, right? If they were taken to the hospital through emergency response and their stuff might be somewhere else, and that can be a whole thing to work through. So I appreciate that recommendation on resources for sure. Well, I want to thank everybody for joining us today. Thank you for bearing with me through my coughing episodes. I always appreciate the kindness and grace of this particular group of folks. I'm going to put my email into the chat here. If you come up with ideas or questions later following today's presentation, please feel free to email me and give us the grace of about a week to get this uploaded with slides and everything on our website. But then that resource and all the different links that are in there will be available to you all. So thank you, everyone, and we'll give you 10 minutes back to your day. Appreciate you and joining us today.